And today I'll be presenting my presentation for you on buprenorphine. So first, buprenorphine and many other names up there. So these trade names include Belbuca, Subutex, Sublocadilate, Brixadi, Buprenex, Butrans, and Probufene. It's a partial mu agonist and a Schedule III analgesic. Buprenorphine, it's a mu and kappa receptor agonist and antagonist combination. So it creates an analgesic effect like other full mu agonists or opioids, but it has a ceiling at the kappa receptor, which decreases the respiratory depression and euphoric effects. On average, its half-life is 38 hours for higher doses and 12 to 24 for lower doses. So I had to include this very large half-life of 25 to 70 hours on the slide. As far as interactions go, buprenorphine is metabolized at the CYP34A enzyme. So if the patient is on carbamazepine or phenytoin, which are inducers of this enzyme, the therapeutic level may not be reached. Now, if they're on an inhibitor of this enzyme, CYP34A, like indinavir or erythromycin, there's a risk of buprenorphine toxicity. Indications and dosage and route. So buprenorphine is commonly combined with naloxone to inhibit opioid dependence. However, the brands I listed previously only contain buprenorphine, and that is the focus of this presentation. Now, buprenorphine is indicated for opioid use disorder, or OUD, at higher doses to block opioid cravings. At a lesser dose, buprenorphine exhibits analgesic effects that can be adequately used for the treatment of chronic or acute pain. Sublingual and buccal tablets are the most common route of buprenorphine, and these are commonly in 16 milligrams per day, but they're split into 2 to 3 doses because the effect typically lasts 6 to 8 hours. Now, the max daily dose of a sublingual or buccal tablet or film is 32 milligrams per day. Injections, which here I'm referring to sub-Q injections, the monthly dose is 100 milligrams with a max dose of 300. I wanted to focus on Brixadi, if I'm saying that right. I hope. It is a new FDA-approved buprenorphine brand as of this year. It comes in monthly or weekly formulations, and the formulations are listed here: 64, 96, or 128 for a monthly dose, and 8, 16, 24, or 32 milligrams for a weekly dose. And lastly, the implant option, which is called Probufene, comes with 4 implants, which are all implanted at the same time, and they all contain 74.2 milligrams, and they're inserted for 16 months at 6 months at a time. Lastly, with the induction of buprenorphine, it may begin you may provide it 6 to 12 hours after the last usage of a short-acting opioid, such as oxycodone or heroin, or at least 24 hours after the last usage of a long-acting opioid, such as morphine. Next, I wanted to talk about special populations. So buprenorphine is not approved for the pediatric population under 16. But given the high rates of OUD in the adolescent population, the use of this medication should be considered and more readily available for adolescents with severe OUD. In the geriatric population, it's recommended to begin at low doses and titrate up as needed. This population is often on multiple medications or polypharmacy, so the risk of drug-to-drug interactions increases, and therefore monitoring their liver, kidney, and heart function closely is important. Now, women who are pregnant or lactating may be prescribed buprenorphine. It is safe. However, it does cross the placenta, and low levels of buprenorphine have been found in breast milk with no adverse effects. Now, monitoring for neonatal abstinence syndrome, or NAS, is important for mothers receiving buprenorphine, especially 1 week following birth. And transmucal routes like sublingual or buccal are the preferred route of administration for pregnant and lactating women. The most common side effects are similar to anticholinergic effects, including headache, nausea, vomiting, drowsiness, dizziness, dry mouth, and some of the adverse reactions that need to be educated to patients to watch out for are respiratory depression. Now, although there is a ceiling effect, the risk of respiratory depression increases when used with other CNS depressors like benzodiazepines. Precipitated withdrawal is another adverse reaction, which is typically followed by nausea, vomiting, and tremors. This can occur when given concurrently or recently after opioid usage. Anemia, constipation, and skin rash are other reactions here. Site complications from the implants or injections like swelling, redness, itching, bruising are common adverse not common, but adverse reactions to those routes. As far as education and monitoring go, patients need to be educated on the kind of route buprenorphine administration they are receiving. So sublingual and buccal tablets or films should be placed under the tongue or inside the cheek until completely dissolved. Now, other forms, the injections and the implants, must be given by the provider. Common side effects should also be a large part of the patient's education, and this includes what to expect and when to seek out medical help, like they're struggling to breathe more. Now, the anticholinergic-like effects, such as nausea, vomiting, drowsiness, dizziness, should be expected, especially when first starting the medication. However, patients need to be aware when they need to seek extra help. For pain and opioid cravings, these should be assessed at every visit, specifically the 5 A's of analgesia, including analgesia, adverse reactions, aberrant behaviors, activities of daily living, and effect. Assessing the patient's opioid cravings will determine the need for an increased dose. Naloxone should also be a large part of the patient's education and its role in reversing opioid effects. This should be kept in the household. And liver function tests should be conducted baseline before treatment, at 6 months, and annually after that when receiving buprenorphine. Determining the patient's hepatic function and also their risk of respiratory depression is crucial because buprenorphine could worsen these. Financially, the standard treatment for OUD is medication-assisted treatment. So Medicare and Medicaid offer the best buprenorphine coverage for OUD. Up to 80% of pain management services will also be covered by Medicare, but the patient will likely have a copay and be required to pay for a portion of the provider services. Private insurance is also increasingly covering this medication, including Anthem, Blue Cross Blue Shield, TRICARE, Humana, and United Health Group. Now, out-of-pocket daily costs have decreased since 2015, but long-term this can be very expensive. They've decreased from about $4.79 to $1.99. Culturally, the usage of buprenorphine is still growing in rural communities, and the 2 communities I really wanted to focus on were the American Indian and Alaskan Native and non-Hispanic white, because these 2 populations had the highest rates of overdose-related death in 2021. Now, as far as treating American Indian and Alaskan Native populations, tribal members place immense focus on holistic medicine and healing your emotional and spiritual being, as well as the physical when you're ill. So coming about prescribing buprenorphine in a much more holistic way and ensuring that other focuses of their being are being just as importantly pushed and made a focus is really important in these communities. And also, as far as negative attitudes go, there is still quite a bit of stigmatism towards those diagnosed with OUD, as well as healthcare providers, having this negative attitude towards patients, and maybe, have a little bit of a shadow over the treatment and perspective that they could provide for a patient because they just view it a little bit negatively. So really trying to shine the light on OUD and recognizing that this is a serious condition that is primarily treated and should be treated with buprenorphine is crucial for providers and patients. Now, my evidence-based practice, the study I chose divulges into medication-assisted treatment for OUD using buprenorphine versus no medication. So Baxley and colleagues analyzed 10 studies that focused on buprenorphine for treating OUD and its effects on reducing opioid cravings. They determined that medications for OUD, or MOUD, resulted in increased survival rates, improved psychosocial functioning, and fostered better patient engagement with their treatment plan. Opioid cravings with buprenorphine significantly decreased upon initiation and over time versus the placebo, concluding that buprenorphine for OUD treatment positively treats and reduces cravings for OUD patients. The clinical practice guideline that I chose that references this evidence-based practice was Recommendation 12 from the CDC. It states that clinicians should offer evidence-based medications as a first-line treatment option to those with OUD. Detoxification by itself is not recommended for OUD because it increases the risk of resuming drug use, overdose, and overdose death. I also added a couple extra bullet points here that just wrapped up the guidelines for using buprenorphine, including that it's a first-line treatment. The initial dose should start at 2 to 4 milligrams once objective withdrawal symptoms are shown and naloxone availability is present for the patient, especially in the household. Lastly, the Substance Abuse and Mental Health Services Administration and the Drug Enforcement Administration determines the prescription regulations of buprenorphine. So this is very important to know as advanced practice providers for how we can provide this medication for our patients who are suffering from OUD. Since the signing of the Consolidated Appropriations Act of 2023, a waiver from the Substance Abuse and Mental Health Services Administration is no longer required for providers to obtain to prescribe buprenorphine in North Carolina. Previously, this waiver, which was only granted after a specialized training process, had to be acquired by the clinician. This really opens the doors for physicians and advanced practice providers to prescribe this medication more readily for OUD. And that being said, what is required is a DEA certification with a Schedule III classification and buprenorphine familiarity. In summary, buprenorphine is a partial mu agonist, and it's a first-line treatment option for opioid use disorder. It's commonly given sublingually or buccally with initial doses of 2 to 4 milligrams, and common side effects mirror those of anticholinergic-like effects. It's increasingly covered by insurance, largely due to more evidence-based studies confirming buprenorphine as an optimal treatment avenue for OUD patients, and supervising physicians must obtain a DEA certification with a Schedule III class medication and be familiar with buprenorphine. And thank you so much. Here are my references.